All right, welcome everyone to Culturally Competent CF Care, which is a very broad topic, and we're going to do our best to cover and talk about some of the key points over several presenters in this symposium. I want to just briefly touch on a couple of things that helped us develop this talk overall when we were putting together this symposium. One was an article by McCary and colleagues that came out in 2019 in Pediatric Pulmonology. And it really talked about a range of demographic factors that can affect outcomes in cystic fibrosis, which was helpful to get us stepping outside of our box of thinking about just the biological factors that affect CF and thinking about some of the aspects of culture and diversity that affect things. While we were putting this together, in addition to COVID occurring, we also had the Black Lives Matter movement that emerged across the country and across the world. And that really influenced our thinking as well when we were putting together this symposium to make sure that we highlighted the voices of Black cystic fibrosis patients. So those two things were really very influential when we put together our speakers and our program overall. And now to introduce some of the people you'll be hearing from today. My name is Chris Drescher. I'm a psychologist from Augusta University, and I am the co-chair of this presentation with Susanna Munzel, who's a social worker here in Augusta as well at the Children's Hospital of Georgia. We're both going to be presenting later on in the talk, and we're going to be really channeling the voices of patients during our two presentations, which we've titled Part 1 and Part 2 of Up Close and Personal with Patients. So we're going to present last, and before then we're going to have a couple of other presentations from other presenters across the country. First, you're going to hear from Nikki Orkowski. She's going to be talking about considerations when working with LGBTQ plus cystic fibrosis patients. So really excited to hear about that. And then next, you're going to hear from a couple of presenters together, two social workers who are going to be presenting on a social work lens around culturally competent newborn screening as it relates to CF. So we're excited to have you all listening and look forward to our discussion after the presentations. And with that, I'm going to turn it over to Nikki.
My name is Nikki Orkowski, and my pronouns are she, her, hers. I'm a child life specialist at Cincinnati Children's Hospital Medical Center and work with patients and families on an inpatient pulmonary endocrinology unit and the outpatient sleep lab. I've been providing child life services to patients with CF for over 21 years. I have experience providing child life services to patients and families who identify as LGBTQ+, and facilitate a support group for patients who identify as gender diverse through the Transgender Clinic at Cincinnati Children's Hospital. In addition, I volunteer with GLSEN to plan educational activities for LGBTQ+ youth and their allies related to safe schools. Today I'm going to be talking about part of my family, considerations when caring for patients with CF who identify as LGBTQ+. I have no relationships to disclose. I want to begin by talking about my objectives for this presentation. I want to discuss the terms used by the LGBTQ+ community, and we'll learn about the patient experience within the CF Center for patients who identify as LGBTQ+. We'll discuss interventions that can be used within the CF Center to support these patients, and discuss the unique healthcare challenges faced by people with CF who identify as gender diverse. Before I begin, I want to talk about why this topic is important and why we're discussing it today. Prior to the discovery of the CFTR modulators, many people with CF had to put social and emotional goals on hold because they were just trying to live. Embracing their sexual orientation and gender identity is one thing that was often put on hold. With CFTR modulators leading to a longer life expectancy, for many people, more adults with CF may now be sharing their sexual orientation and gender identity with their care team. And younger people with CF may begin to share this information at even younger ages. So I want to go over some of the terms that are used most often. Just remember that terms and definitions change frequently. And if a patient uses a term you're not familiar with, ask them what that term means to them. Sexual orientation is one's sexual interest towards members of a certain sex. Gender identity is one's inner sense of being a man, woman, or some other identity. Cisgender is a person who has a gender identity that matches the gender they were assigned at birth. A lesbian is a female-identified person who's attracted romantically, physically, or emotionally to another female-identified person. And someone who is gay is usually a male-identified person who is attracted romantically, physically, or emotionally to another male-identified person. Some females prefer to call themselves gay instead of lesbian, so you may hear females also use the term gay to refer to themselves. Bisexual is a person who's attracted romantically, physically, or emotionally to both men and women. And someone who is transgender is a person whose gender identity does not match the gender they were assigned at birth. Queer is an umbrella term which embraces a variety of sexual preferences, orientations, and habits of those who do not adhere to the heterosexual and cisgender majority. Questioning is the process of exploration by people who may be unsure, still exploring, or they might not want to apply a social label to themselves related to their sexual orientation or gender identity. The plus is inclusive of anyone who does not identify with any of the previous terms. I want to mention a couple of other terms that you may hear that I've heard more often lately. Someone who is pansexual is a person who's attracted romantically, physically, or emotionally toward people regardless of their sex or gender identity. I often get asked what the difference is between bisexual and pansexual. Someone who is bisexual still looks at the binary of male and female, whereas someone who is pansexual would be in a relationship with someone regardless of their sex or gender identity, which means that they may be in a relationship with someone who is transgender. Pansexual is a sexual orientation that more people have begun to identify with in the last few years, so you may hear this term quite often. Someone who is gender diverse, that's a relatively new term that describes people with a gender identity that's different than what's typically assigned to their birth gender. So people who identify as gender diverse may also identify as transgender or any of a number of other gender identities, including genderqueer, gender fluid, or non-binary. Coming out is the process of telling others about your sexuality and gender identity, which we'll talk about in a little while. The healthcare experiences of people who identify as LGBTQ+ is quite varied. But many people, especially those who are transgender, have a long history of discriminatory healthcare treatment and often do not trust healthcare providers. The 2019 Human Rights Campaign Healthcare Equality Index showed that many people face identity-based discrimination. In this survey, 56% of lesbian, gay, and bisexual people reported identity-based discrimination within healthcare, and this number was even higher for transgender patients at 70%. Healthcare avoidance is also very common and can result in a delay in care. 33% of people surveyed delayed care for the fear of discrimination. There's also a lack of healthcare professionals who are trained in LGBTQ+ medical and behavioral health care, and 50% of transgender people report that they had to teach their doctor about transgender care. The coming out experience or disclosure is something that's also often very difficult for people within the healthcare experience. There's a study that was done looking at disclosure to a primary care physician, and that was seen to be as challenging as coming out to family and friends, especially for younger patients. One patient in the study stated, "It feels awkward to tell the doctor you've had since you were born your sexual orientation." It can often be hard just to say the words out loud, and if the question is not asked, patients may have to make an intentional effort to share their sexual orientation and gender identity. And the research study that I referred to was looking at disclosure to primary care physicians, but I would venture to say that people with CF feel the same way about coming out to their CF care team, because these are the doctors and other staff that they've had since they were babies, and so it may be harder than coming out to their family and friends. So how can we make disclosure easier? Over 1/3 of lesbian, gay, and bisexual adults avoid disclosure to medical providers. It's important to offer a supportive environment that has LGBTQ+ positive signage and resources available that relate to various sexual and gender identities and sexual health. It's important to directly ask about sexual orientation and gender identity and ask early in the relationship. You can actually set an age to begin discussions with all patients, regardless of your assessment of whether they may be LGBTQ+ or not. You can include questions in the electronic medical record that decreases the burden to disclose multiple times or in multiple settings. And LGBTQ plus inclusive paperwork can include open-ended questions where people can write in their gender identity or their sexual orientation that they like to be referred to. It's important to build a strong therapeutic relationship throughout your time with the patient and view the patient as a whole person within a social context rather than just a person with CF. This shows compassion, professionalism, and being patient-centered, which helps to foster trust. A patient coming out to you is a special moment and shows that they trust you, so it's really important to embrace that trust. Communication is so important, so we need to utilize gender-neutral language throughout our relationship with patients. One study found that heteronormative language had a negative influence on patients' perceptions of their doctor. One example of heteronormative language that I think is quite common is making assumptions about people's relationships. If you are seeing a female patient and you ask if they have a boyfriend, or a male patient and you ask if they have a girlfriend, that's heteronormative language. A better way to ask this question is just to say, are you dating anyone? It's important to assure the patient of confidentiality because many fear who the medical staff will tell, including their family. They may not be out to their family yet, and they may not feel comfortable coming out to their family at this point. The response to the disclosure really matters. There have been a couple of research studies looking at healthcare providers' reaction to disclosure, and it ranged from surprise to uncomfortable, unhappy, disbelief, and acceptance, which was labeled to be welcoming and understanding. One patient actually said, "My doctor accepted me as I am." No reaction was actually found to be the most common reaction, and they hypothesized that the doctors may think that no reaction is a way to normalize the disclosure. But the patients saw the lack of reaction as indicative that the doctor was uncomfortable, so this was seen as a negative reaction. It may help to avoid a negative response by not having a response at all, but it's also a missed opportunity to build connection and provide support. Many people actually expect a negative reaction from disclosure and are surprised when the reaction is more positive. One patient stated, "My doctor didn't care that I was gay, and he still treated me." It's important to thank the patient for confiding in you because the chances are this was not an easy thing for them to do. There are some special considerations for patients with CF who identify as gender diverse. One is PFT interpretation. As we know, one factor in interpreting PFTs is gender. So patients who identify as transgender present a unique challenge to the care team. You have to make a decision whether to interpret PFT results based on the patient's gender that was assigned at birth or their gender identity. And this decision can have a significant impact on PFT interpretation and results. If you're going to interpret using the gender that was assigned at birth, I heard that one physician would tell patients, "I'm going to compare you to you," because they were looking at their PFT interpretation throughout their life and their PFT numbers throughout their life and not comparing them with other people of the gender that they were assigned at birth, which made the patient feel a lot more comfortable. Chest binding is something that is done by people who were assigned female at birth but identify as male. And this is when you wear a binder to create a flat appearance to their chest, especially if they've already gone through female puberty. There's limited research regarding the effect that chest binding may have on lung function, and the research that has been done was conducted with adults who did not disclose any pre-existing lung conditions, including CF. Some of the effects of chest binding include shortness of breath, respiratory infections, digestive issues, heartburn, and pain in the chest, shoulders, back, and or abdomen. But despite the physical impact that many experience with chest binding, the majority of people who engage in this practice report a positive effect on their mental health. People with CF who identify as transgender and their medical providers may need to weigh the physical harm that can be caused by the use of a binder with the impact on their mental health and quality of life. Alternative treatment to chest binding, including chest reconstruction surgery, may be explored. This is often not done until the age of 18, but may need to be done earlier to protect the mental health of patients with CF. Drug interactions are also seen between CFTR modulators and hormones that people who are transgender may be taking, both testosterone and estrogen. Trikafta and Symdeko can cause hormone levels in the body to rise. Kalydeco is less likely to cause hormone levels to rise, but could still have some effect on the hormone levels. and or can be, on the other hand, may cause lower levels of the hormone to be present in the body. So what this means is that there's a need for closer monitoring of hormone levels and possible dose adjustments for people who identify as transgender and are taking hormones and CFTR modulators. What do patients want you to know and do? They want you to talk about their sexual orientation and gender identity early in the relationship. They want you to avoid assumptions based on whether there's an M or an F for male or female on the paperwork, and ask medical questions about their organs and hormone dominance that they have right now. Ask patients about their support system, especially when working with adolescents and young adults. And this is their support system outside of their biological family. This can open up lots of conversations about who is supporting them and what are their relationships. It's important to use sensitive and respectful language. This helps people to feel seen, heard, and valued, and communicate safety. We can show patients that we care about who they are and what they need as people and not just patients. And use language on forms that allow for accurate information about sexual orientation and gender identity. It's important to be supportive when a patient who identifies as transgender speaks about transitioning. For people who are transgender, social and surgical transition can be a very big step, and often it can be an emotional and confusing time. Transition can have a significant impact on their mental health. So it's important to be supportive when they decide that they want to transition. Consistency is also important, to have consistent medical staff so they don't have to answer the same questions and explain the same things multiple times. And using the chosen names and pronouns consistently. Have pronouns listed prominently on all paperwork so that everyone knows the patient's pronouns and also their chosen name. This shows respect to the patient, which is very important. You can also show your pronouns with patients. I know a lot of places it's become more common for people to introduce themselves and then say their pronouns. Like I would say, my name is Nikki and my pronouns are she, her, hers, which also is showing respect and giving the patient an opportunity to share their pronouns. I would like to thank the following people for their help in putting this presentation together. Please submit questions in the Q&A box to be considered for the live panel discussion. You can also reach out to me on the networking platform if you would like to have a discussion on this topic any further.
Good morning. Welcome to our workshop, Providing Culturally Aware CF Care, a review of newborn screening through a social work lens. I'm Ethan McCormack, and I have no disclosures.
And I'm Randy Lubin, and I have no disclosures.
So we're just going to take a minute to tell you a little bit about ourselves. So again, I'm Ethan. I use they, them pronouns. I'm a pulmonary social worker at Seattle Children's Hospital. I have a master's degree in social work from the University of Michigan, go Blue. And I have my license to practice social work.
And I'm Randy Lubin. I use she, her pronouns. I'm social work faculty at the University of Arizona's Pediatric Pulmonary Center. I have my license and I got my master's from Arizona State University in social work. So just a brief agenda of what we are hoping to talk about today. Regarding newborn screening, we're going to talk about what is the history of newborn screening and CF. We're going to talk about what the current guidelines are and where we hope to go and what we hope for going forward. So a brief history of newborn screening. It began in the 1960s when they were trying to develop a way to test for PKU. And over time, and with the help of HRSA and MCHB, it has expanded across the states. And then by 2002, the Maternal Child Health Bureau and American College of Medical Genetics created some guidelines for newborn screening. By 2003, the majority of states were screening for at least 6 disorders. And then by 2011, all states were screening for at least 26 disorders. And today, all states screen for at least 29. CF specific, we developed the screening in 1979 to measure IRT and dried blood spots. The first newborn screening program for CF began in Colorado in 82, followed by Wisconsin in 85 and Wyoming in 88. By 1997, the CDC convened a workshop that reviewed all of the state of scientific evidence available on newborn screening for CF, and they formulated recommendations. And then in 2003, the foundation and the CDC got together. They reviewed the evidence, the benefits, and the risks, and decided to add newborn screening for CF to the newborn screening guidelines.
So the current newborn screening guidelines were revised in April of 2019, and we just provided a few important highlights for those newborn screening guidelines. And so one thing we wanted to point out is that they developed a screen that finds infants most likely to have CF, that avoiding sweat tests for infants less likely to have CF is important, that due to a variety of reasons, contacting the family doctor and the family with newborn screening results, as well as providing counseling for families and discussing next steps. So in order to talk about providing culturally aware CF care, we thought it would be necessary to talk about who has CF according to the Foundation's patient data registry. So as you can see here, and this may be information that folks are already familiar with, 4% of African Americans have CF, 3% quote unquote other race has CF. You see the 9% that is both non-white and white Hispanic that have CF, and then 93.5% is white folks that have CF. So we are about to get into the importance of this data.
So we want to highlight one of the theories, the theory of functionalism. And what it says is that the theory is that all aspects of a society serve a function and are necessary for the survival of that society. Nash in 1964 states that functionalism focuses on the way racism is functional for the dominant group. For example, suggesting that racism morally justifies a racially unequal society. So we want to talk about race and NCF, and we want to look at all aspects that it serves a function and is necessary for the survival of the society.
And so again, in relation to functionalism and specifically cystic fibrosis, we wanted to look more at what is the function of highlighting that CF is a predominantly Caucasian disease. We know based on the raw data, this 93.5% that it is, but we want to talk a little bit more about how that functions. And so along those lines, one of the things that we decided to look at, which is just sort of the beginning of looking at this data, is how does each state in the US describe CF as a disease when they talk about who has CF? And so we went state by state and looked at each Department of Health. Do they specifically state that CF is a Caucasian disease? Do they not provide any description based on race? Are there links to other websites? Or was there no description at all? And so what we found from this is that 54% of states' Department of Health still refer to CF as a predominantly Caucasian disease. And so we are about to talk about why that is potentially problematic. A racist idea is any idea that suggests one racial group is inferior or superior to another racial group in any way.
So let's talk a little bit about intersectionality. Kimberly Crenshaw in 1989 coined intersectionality, and she describes how race, class, gender, and other individual characteristics intersect with one another and overlap. She also highlights that when scholars fail to embrace an intersectional approach to subcultural studies, they run the risk of devaluing identities and misunderstanding the various oppressions that may contribute to the culture and practices of a subculture.
So intersectionality within the context of CF looks at, what are the potential experiences of a person who is not white who has cystic fibrosis. And so one of the things we were able to locate was a blog post from the foundation by a gentleman, a young adult with CF named Bobby Foster. And a couple of quotes that we thought were really important are the following. So, having cystic fibrosis as a Black man means being left out or misunderstood. I want to be heard, acknowledged, and represented. I remember thinking, but that's what I look like. Do I not have a right to be represented? Am I not good enough to be represented? What's the problem with being Black with CF? And this one in particular really stood out to us. It means that when I go to the hospital, it isn't until my white mother shows up that I get treated equally. It means being denied proper medicine, attention, and treatment until they realize that I'm half white. So again, when we fail to embrace an intersectional approach to how we provide CF care, we are potentially denying proper medicine, attention, and treatment.
We wanted to highlight a few quotes from Ibram Kendi's How to Be an Anti-Racist book, and regarding newborn screening and talking about racial inequality. And he states that racial inequality is a problem of bad policy and not bad people, right? So we want to highlight what are the newborn screening guidelines and what's going on right now that is furthering the gap in health inequity. And we want to be looking at these things because he points out that denial is the heartbeat of racism. And these are things that we have to challenge ourselves and we have to look at. So in social work, we have some code of ethics that we practice by, and one of ours is cultural awareness and social diversity, and what it says is the value is the dignity and worth of the person, and the principle behind it is that social workers respect the inherent dignity and worth of the person. And we do that by caring in a caring and respectful fashion. We're mindful of individual differences and cultural and ethnic diversity. In an effort to keep these theories of functionalism and intersectionality in mind, we also really want to promote client socially responsible self-determination. And we're cognizant that we have this dual responsibility to both our clients and to the broader society. So we are highlighting the diversity of our CF patients and what we're looking at.
We also have an ethic related to social justice. Our ethics says that we challenge social injustice. So part of our goal here today, for example, is to pursue social change, is to pursue the way that changing the way that we talk about cystic fibrosis and who has this disease. We are also bound to focus on issues of poverty, unemployment, discrimination, and other forms of social injustice, which we know are, including race, are all social determinants of health. We also ensure access to needed information, services, and resources.
So one of the ways that we want to challenge ourselves is we are going to look at implicit bias and what it is. Implicit bias is the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. The key attributes for implicit bias is it's implicit, the bias, and it's involuntary, and it's pervasive. Harvard's done some studies where they have the testing, and you can take a test on what kinds of implicit biases you might have in all different areas. And one of the test they have is for preference for European American over or compared to African American. And so from 2002 to 2015, they collected all this data, and here's the graph. And so 68% up to 2015 of people still had an automatic preference for European American compared to African American, right? And then in 2018, the systematic review was done in healthcare providers that found evidence of pro-white or light-skinned and anti-Black, Hispanic, American Indian, or dark-skinned bias among healthcare providers. So what we're saying is this is still a problem. This is still something that we have to challenge ourselves and we have to face. Rudman says that for a deep and lasting equality to evolve, implicit biases must be acknowledged and challenged. To do otherwise is to allow them to haunt our minds, our homes, and our society into the next millennium. And so we want to really look at what implicit biases do we have, and particularly in our CF population. So we also wanted to see what research and literature was already out regarding cystic fibrosis and culturally aware and sensitive care. So here's a couple of quotes from the publications that we found from our lit review. Research has since shown that CF is not ethnically linked. The notion that CF only occurs in white children has lingered. A consequence of this lack of data is the fact that there are more likely to be false negative results for a patient with CF who is not white. This may result in delayed diagnosis, which can negatively impact a patient's health. This is from the publication titled CF in African Diaspora from 2016.
We also found this quote from the CFTR.org and Newborn Screening Guide for Parents in Arizona. CF is an autosomal recessive disease. A child could have one common CF gene mutation and one uncommon CF gene mutation. Only the common CF gene mutation would be detected in the newborn screen. This panel of 23 common CF gene mutations accounted for about 92% of CF disease. At this time, there are over 2,000 known CF gene mutations. That's why the positive newborn screening needs further evaluation. And this is also why we wholeheartedly support Pathway to a Cure and finding more treatment for people with rare mutations. So this is our quote that kind of that we found in our literature that kind of wraps everything up in a nice bow for what we've been talking about. An equitable identification of CF in non-white versus white groups persists because mutation analyses often use newborn screening and are diagnosed. I can't see it. Okay, hold on, friends. I gotta move my face. Okay. Inequitable identification of CF in non-white versus white groups persists because mutation analyses often used for newborn screening and or diagnostic testing are not as effective overall in detecting the CF variants prevalent among non-whites. Non-white patients may be diagnosed more frequently based on symptoms rather than through a newborn screening algorithm or molecular diagnostic testing, because the testing panels in use do not sufficiently include the variants that are prevalent in non-white populations. So again, what we're saying is we need to expand how we're doing newborn screening so that it is more equitable and inclusive.
Right. Yeah, what we're saying is the correlation does not equal the causation. And by continuing to use the language around cystic fibrosis being a Caucasian disease, we're really missing out and we're marginalizing the populations. And it's not factual.
So in addition to that, and maybe at this point, maybe not, you might be asking, okay, so what? So what does this have to do with the CF community? What does this have to do with us? The CF Foundation website actually recently asked this question, and the answer that they gave is despite an increasing proportion of minorities with CF, people of color in the United States are more likely to experience worse health outcomes, receive a delayed diagnosis, and be underrepresented in clinical trials. We will not accept these inequities. And while we have begun tackling the challenges in these areas, we still have much work to do. So what is the work that we have to do?
Well, we want to challenge you to look at your specific discipline's code of ethics and what does it say about diversity and equity, inclusion, and how are you practicing that within yourself, in your individual, and then in your workplace? What policies does your CF Center have in place about newborn screening and equity and inclusion?
How are you challenging your own personal implicit bias? Are you aware of how you're talking about your patients? Are you aware of the assumptions that you might be unintentionally making? And another important quote from our lit review, so when racial associations are part of the everyday medical lexicon, what do we actually learn? What do we miss? And who do we marginalize?
So if you're thinking about CF specific, when we associate race with newborn screening, with diagnoses, right, you can think about those questions. What are we actually learning? What do we miss? And who are we marginalizing? So we have a list of resources. It's by no means fully comprehensive. It's just what we used and what we have. I know there's a lot more out there. Please, if you know of more and you're using more, share them with us, and then we can share them out when the slides go out as well. The first two on this list are CF specific, but I know there's more out there.
And then the one that under our reading list that I just want to quickly highlight is called White Privilege, Unpacking the Invisible Knapsack. So if you're someone who's unfamiliar with what is this, what is racism, what is white privilege, this article by Peggy McIntosh really succinctly helps you understand what that looks like.
So these are our references that we used for this project. And if you guys have any questions, please, you're welcome to email us. Also come back for the discussion and the Q&A session later today. And thank you so much.
Yeah, I believe that's at 3:30 to 4:30 p.m. So we hope to see you there. Thank you.
Hi, this is Up Close and Personal with Patients and Parents. My name is Susanna Menzel, and I'm a licensed clinical social worker at the Children's Hospital of Georgia. I have no relationships to disclose. Culture is defined as the integrated pattern of human behavior that includes thoughts, communications, actions, customs, beliefs, values, and institutions of racial, ethnic, religious, or social groups. Cultural competence is a set of congruent behaviors and attitudes and policies that come together in an agency or among professionals that enable them to work effectively in cross-cultural situations. We are culturally conditioned by our interactions with the people who are culturally similar and different. These interactions can be both positive and negative. As a result of being culturally conditioned, we form definitions of what we consider to be normal and acceptable behaviors. Self-awareness is one of the first steps to being culturally competent. Think about your personal experiences with someone of a different culture. What were your first thoughts? How did you approach the person? Did you change the words that you used? Did you think about what it is like in their home? Did you think about what steps they had to take to get to clinic that day? We naturally assume that everyone perceives and experiences the world as we do, members of our own ethnic, racial, or cultural groups. This is basic and ingrained, buried deep into our consciousness, so deep that we continuously act and react without even thinking about it. As we move through this continuum, we must transform our thinking to fully acknowledge and appreciate the person and their perspective from their culture. I wanted this talk to include families that we would not usually hear from at conference, maybe due to financial burden, limited resources, or language barriers. I reached out to 2 families in hopes to dive into their culture and their experience with CF, the CF team, and the team dynamic, or culture, so to say. Meet M and G. G is 15 years old and he is in the 9th grade. He was diagnosed at 4 months old. Mom is from Mexico and the patient was born here in the US. Mom is single as dad passed away when the patient was younger. Mom is a farmer and they have very limited financial resources. The patient has Medicaid and does qualify for supplemental security income. They also receive food stamps, and this family is dependent on Logisticare for transportation. I asked Mom what her initial thoughts were to the diagnosis, and I think she had a very normal reaction, surprised. And despite all of the medications and treatments coming to clinic so frequently from so far away, M describes that the patient had a normal childhood. This family travels about 3.5 hours each way to come to clinic. That's a 4 a.m. pickup for an 8 o'clock appointment, with the expectation of doing a treatment prior to leaving the house, of course. There have been several times when Logisticare has not been able to find a driver to pick them up for the appointment and the family had to reschedule. There's even been difficulty with Logisticare finding a driver at hospital discharge, and they've sometimes been stuck here in Augusta with limited money to buy food. Mom does not appreciate any difference in care due to being Spanish-speaking only, thankfully. My initial reaction when I read this was that our team might have a different answer. We do have interpreters that come to clinic, and they also assist with phone calls. Our team has contacted the local pharmacy to make sure that the prescription labels are printed in Spanish. Our checkout sheet for clinic is still in English, but we do read over it with the interpreter there in the room. This family is not eligible for certain grants due to Mom not having a Social Security number. However, Children's Medical Services is able to cover the copay for certain prescriptions as needed. M encourages CF parents to have a lot of patience. She is grateful for the work of our CF clinicians and all CF clinicians and wants us to continue to search for the cure. Now I would like you to introduce H and E. This family is low income. The patient has Medicaid, SSI, food stamps, and they receive housing assistance. Mom works part-time at a fast food restaurant. Another dynamic with this family is that the patient also has autism. Mom had a different reaction to the CF diagnosis, which I think is also appropriate, asking, what is cystic fibrosis? And then, will I be able to take care of him? Overall, the patient was described as a happy kid, and dare I say a normal boy, playing all the sports and getting into everything, at least until he was 11 when he got a G-tube. This family travels about 3 hours each way to come to clinic. Of note, this mom always makes it to clinic. It doesn't matter if she is scheduled to work, she will switch her shift. If her mom is not able to bring them, then she will trade cars. If the patient gets admitted, she will miss work for 10 to 14 days and find childcare for her daughter, and that's without getting PTO. I captured several quotes here, but I would like to read this section directly from Mom. The question that I asked her was, does your family ever have trouble meeting their basic needs, like having enough food, paying bills, or having a safe place to stay? If so, how does it affect your family, and what resources do you use? Mom said, I'm currently not working due to the amount of contact my job has with people all day. But prior to the pandemic, we were doing pretty okay with the resources I have available. I'm a single parent. I do not get any support from their father, no child support, no babysitting, no mental or physical support, so it's just me. I do get food stamps and Medicaid through the state, and my social worker got me in touch with our local food bank to help with additional groceries when needed. I work in fast food, as it has been the only field that is really flexible with my schedule dealing with me and my kids, especially having a child that has cystic fibrosis and autism. I have contacted the CF Reaching Out Foundation for help in the past to pay a bill. Since I've been out of work, my social worker gave me information for Miles for CF, and they helped me with a partial payment on my electric bill. I have used Children's Medical Services to help pay for my son's Pediasure supplements. The resources my social worker has provided for my family has been more than I could have ever imagined. It has really helped to ensure that we would have electricity or a meal to eat, or even buying my son's medications day by day. She has found donors to help give my kids Christmas during times when I didn't think my kids would have a Christmas, at least not a good one. And she got me in contact with my son's favorite place in Augusta, the Ronald McDonald House. It is the highlight of his times coming to the doctors. This mom, similar to earlier, also noted that patience is key. But then she stressed the importance of communicating with the CF team. When her son was fighting against her and skipping treatments and some medicines, she didn't want to tell the team, and when she did, she was grateful. Mom was met with support from the team. They talked to the patient and worked with him to create treatment goals with the incentive of getting a Walmart card. It's only $10, but that's a lot for a kid. This also made Mom feel better about herself. Instead of making her feel like she was failing, they normalized this behavior and provided support for her to keep working with the patient and his knowledge of the disease and the importance of doing treatments and taking the medications. Another thing that Mom noted is that the pulmonology clinic always asks both of them questions and keeps them in the loop as to what is going on and helps her know what she can do to improve her son's health when he's admitted. When he's admitted, the staff treats him like a person and not just a sick kid. Mom notes that people don't believe how great her team is until they actually see it. Cystic fibrosis is most prevalent in non-Hispanic white patients. However, as the United States population becomes more racially and ethnically diverse, minorities represent an increasing portion of patients. We think of race and ethnicity as social constructs, but they have important health implications. Minorities tend to suffer worse health outcomes. We must continuously challenge ourselves to come from a perspective of racial equity and racial justice. Again, culture is very complex and includes the person as a whole. Being able to meet patients and families where they are will enhance the care they receive and increase the support system around them. As providers, we must also consider how social determinants of health impact the patient every single day, not just the days when he or she is in clinic. The health of a patient is impacted by so much more than how compliant they are with their treatments. Barriers to the treatments and coming to clinic must be considered for best health outcomes. We must remember to engage and partner with the patient and family and listen to what they have to say. Culturally competent care includes all races. With the tragic events that have occurred all over the country, we want to highlight this young lady. Rayshawn Jones is an African-American woman with CF. I will let her tell her story. For more information, you can go to attainhealth.org and look under the Peer Engagement tab. Here's Rayshawn.
Hello. Thank you all so much for having me on here. I'm super grateful for this opportunity. I'm super grateful to be on here and be able to share a little bit about my life with cystic fibrosis. Thank you, Susan, for this opportunity. Thank you for messaging me and asking me to speak on my experience. So a little bit about myself. My name is Rayshawn Jones. I was born and raised in Richmond, Virginia, and I'm an upcoming senior at Virginia Commonwealth University, and I'm super excited. I'll be graduating in May of 2021 with my degree in psychology. So I'm super excited to be able to finish up my undergrad and move on to the next stage that God will have me to move in life. So yes, I'm 26 years old. I was diagnosed with cystic fibrosis at about 3 months old, where my mom was told my life expectancy was 13. So I'm super grateful to be able to have surpassed 13. I don't recall having any crazy stories or anything like that as far as my diagnosis, but I do know that I was diagnosed, it was the last thing that I was tested for. So they had did sickle cell and a whole bunch of other tests, and then when it did come back that I had cystic fibrosis, they were very surprised because they were like, wow, we've never seen an African American with cystic fibrosis. So at the hospital that I was diagnosed at MCV, it was just very, I guess they were very surprised to see that I did have cystic fibrosis, and I was a black little baby with cystic fibrosis. I have a twin brother. He doesn't have cystic fibrosis. He was fine. So I think that was a reason why my mom really wanted to push for them to try to figure out what exactly was going on with me. So growing up, as a child having CF, I didn't realize it was difficult until I became an adult. I didn't really it was hard because nobody really knew what CF was. None of my peers knew what CF was, so I kind of felt like the outcast, and I feel as though I tried to hide it a little bit, just because it was awkward. It was a difficult conversation to talk about. And then when I was 9 years old, I got diagnosed with type 1 diabetes. So, you know, we're talking under 10 years old, 2 chronic illnesses. It was just a really weird thing to talk about. So as I got older and I wanted to learn more about it, within the last year or so, I would just get on YouTube and just try to find people like myself that have CF. I've only met one Black person with CF in my entire life. So before I, got on YouTube and began looking, and people came up with CF, people showed up, but there was no Black people. So I was like, why is this? I know there's not just me with CF, so I prayed about it, and then I started my brand, Spiritually Breathing, and I started off with changing my Instagram name and then creating a YouTube channel where I just educate the community on CF. I have created a safe space for people like myself that are African American with CF to be able to just come and, just feel like, hey, she's like me. And it's been an awesome opportunity. I've been given opportunities to speak on my life with CF ever since. I've been offered the opportunity to start a virtual support group for Black people with CF, which I did start. So we meet every Wednesday at 7 p.m. Eastern time, and we just get on there and we talk about what's going on in our communities, the state of our nation now, how we feel having CF, and we've actually realized that we have a lot more in common as far as being Black and having CF than we thought we did. So yeah, we meet every Wednesday at 7 p.m. Eastern time, and it's just a good feeling to have people like myself where we can just get and meet and talk about how we deal with things on a day-to-day basis. And since starting that, I've had people ask me, how is it being Black with CF? How is that for you? Obviously as people that may not be African American, and I never realized that it was really a difference until this year. Actually, I had went in to get a port put in, and a fellow CFer, she's a white woman, but she talked to me and she just told me her experience on getting the port, and I was like, okay, wow, this will be awesome. I'm really excited about it. She told me that the procedure, she was sleeping, she didn't really have any awareness of what happened after she got back to her room and woke up. Whereas for me, going in to get the procedure done, I was awake the entire time. I had expressed that I was in pain, that I could feel what was going on, and I was not offered any more medicine or anything to kind of subside the pain that I was dealing with. So going through that procedure and then having to heal from the procedure afterwards made me think like, wow, did I get treated differently, because I am an African American woman, and I never want to be that person that says like, oh, well, it's because you're this race and I'm this race. But I think that is the best conclusion that I could come up with. And it's just a hard time in our nation, being Black, and people not accepting us, or people not thinking that we're worthy or thinking that we're less than. But one thing that I can say about the Black Lives Matter movement is that it's just exciting to see people of different races and nationalities coming together, supporting Black lives, and kind of standing up and saying, hey, their lives matter just as well as our lives. So I think that is the upside of what's going on, even though I feel this shouldn't even be a thing. But if I have to look at a bright side out of it, it is very mentally draining and overwhelming, but it does make me smile when I see people that I go to school with that are going to protests and speaking out and posting on their social media pages that Black lives do matter. And on top of what's going on in our country with the racism, and then COVID coming over and taking over, it's just been a difficult time. I think my doctor, he's always, Dr. Chaudhry, he's always been the person that is very into his career. He's very into going to CF conferences and figuring out how to make our lives better. So, you know, he has given us advice and tips on how to stay safe during COVID. For me personally, I would rather just take care of myself to my best ability at home and not have to go into the hospital because I don't feel safe with COVID and everything that's going on. And I think something that really frustrates me is people not taking it seriously. My friends, my family, they do know that I have CF, so they take it seriously. But, you know, people even going on these tangents about they don't want to wear masks and things of that sort. I just think that if they were a little bit more educated, that there are people out here like ourselves with cystic fibrosis that already have a compromised immune system. So I don't think it would be difficult for you to put on a mask. It's just, I think COVID is a difficult time for anybody. But for me, myself, I just continue to pray and I just ask God to just keep me covered, keep my family covered from COVID. But if I could give any advice to any physicians as far as how to better care for us, it would be to listen to us. Listen to your patients in general as to how they feel, what they feel they need. Too often, being impatient, I see physicians come in and they want to try to treat me as the next CF patient a few doors down, and it's like, you know, we're not the same. And I have noticed that I've had the best experiences with nurses and with physicians who come in, show that they have a caring heart, listen to, okay, what is it that you think will help you to feel better so we can get you out of this hospital, and so that this isn't a reoccurring thing. You know, your lung infections are happening more often. What can we do? And just listening to maybe what I struggle with. Maybe I am, you know, I'm a full-time student, I work, maybe I just have a lot on my plate. How can you all better assist me to make my care better? But I think as a whole, the healthcare system would do a lot better with just listening to us and just treating us with the same respect as they would treat another patient. And even if, you know, we may be headstrong and maybe the next person may not be, still understanding that we do live with a chronic illness and we deserve respect as well. So I want to thank you guys for allowing me to be on here. Thank you so much, Miss Susan. If you guys want to keep up with me, you can follow me on Instagram at Spiritually Breathing, Facebook at Rayshawn Jones, and I'll be more than open to filling you in about my virtual support group and just to be there to be a friend. So yes, thank you guys so much. Have a great evening.
All right, welcome. This is part 2 of our up close and personal presentation. This one will be with a middle-aged African-American patient and his spouse. My name is Christopher Drescher. I'm from Augusta University. I do receive some research funding from the Boomer Esiason Foundation for a research grant looking at acceptance and commitment therapy for cystic fibrosis patients. Otherwise, I have no disclosures. The story we're going to be talking about next is the story of Terry and his wife, Michelle Wright. Terry was diagnosed at a later age with cystic fibrosis. Terry and Michelle have worked together to create the National Organization of African Americans with Cystic Fibrosis. And although we'll be viewing a video of their story today, you can also check out another version of Terry's story through his children's book that he recently wrote.
Hi, I'm Terry Wright.
And I am Michelle Wright.
Welcome to my CF journey.
No, Terry, our CF journey.
Oh, yes, you're right, our CF journey.
And by the way, happy anniversary.
Thank you, and many more. 57, of course, Black male, and my journey with CF has been from birth. And what's so ironic about it, I was only recently diagnosed 2 years ago. So my journey with CF of sickness, I've constantly stayed in and out the hospital since a child. Children's Hospital, and they normally would just say that he has a bug in his stomach, a virus, and just kind of send me home, shoot me up with Demerol, Finnegan, and just kind of relieve the pain, just tentatively. But it seems to come right back a couple of days later, so the pain can last up to a couple of weeks, constantly, pain, just like someone to kick me in my stomach. And my journey also with the CF, patients experience it different. It attacked my GI system when I was much younger. Ended up having a Whipple surgery when they removed a piece of my pancreas and one of my ducts. And that was in 2001. And shortly after that, I just started having a whole lot of chronic pneumonia, chronic sinusitis. It was just wreak havoc on me. And I was just wondering what's really going on with me. I knew I was not normal. I had breathing issues. Even as a child, I had breathing issues. I thought it was like a seasonal asthma, but come to find out, it all relates back to the cystic fibrosis. And a lot of people come not diagnosed, especially being a Black African American. You just can't say, well, you have a cold, you have pneumonia, you have sinusitis. They don't really do the research and take you through the things that they probably need to take you through. So I was recently diagnosed in 2000 once again with the cystic fibrosis. And when I was diagnosed, they sent me to a children's hospital. It was so ironic. The same place that kind of kicked me out was just saying it was a virus. They diagnosed me. I have good days and bad days. For the most part, I try to stay very active and very positive attitude about it. And keep in mind, I was only recently diagnosed 2 years ago, but I've been living with this disease from birth. And my understanding, both parents got to carry that gene. And so that's how I ended up with the cystic fibrosis. And that's my story.
To me, it's amazing, him being both African American and almost 57 years old.
Mm-hmm. And having CF. Well, I think it's amazing. It's really weird. Yeah, because normally it's a white kid's disease and they don't live past 18 or 20. But with modern medicine, things are getting better and everything. Wow, you're just a walking miracle with you.
You don't think of a Black man with cystic fibrosis at all. That's normally a Caucasian disease. They find it in other races now, but it's normally that gene carries in the Caucasian race. And they usually be shocked, especially of my age, 57, with cystic fibrosis. Come to find out, like I said, within 2 years ago, was diagnosed with the cystic fibrosis. So everything just like revelation to me now. Now I know why I think the way I think and why I feel the way I feel now, that this is not normal. Knowing what I know now with the cystic fibrosis, I probably, in fact, I won't probably, I know definitely my diet would have been different. I would have been concentrating more on eating even more healthier, more good organic green foods. Drinking plenty of water, that's very important. You have to move that mucus and dilute it as much as possible. And of course, anything that's going to cause my lungs to work, my lung function, would be cycling, running, jogging, something gonna cause me to breathe deep into my lungs. These things right here is very healthy for the CF person, to be very active working those lungs, because if not, stuff will just sit there and just be stagnant. You want to move that. So to help it move, work those lungs. So if I know what I know now, I would have been more active.
Advice do you have for other cystic fibrosis patients in general and African American cystic fibrosis patients specifically?
My advice is to hang in there.
Okay.
Stay encouraged. Because they're steady coming up with different improvement and ways of making your quality of life much better. It's cystic fibrosis patients. So just hang in there and try to stay encouraged. Support to me is everything, because you see people in your corner, for instance, my wife, and excellent support, because if it really wasn't for her, I probably would have died in 2000, because that's when I had that pancreas surgery, the Whipple surgery, when they removed a piece of my pancreas in one of my ducts. She encouraged me and just kind of baby me through the whole deal there, so to speak. And of course, I can go all the way back to mom as a child, just having my mother as that support. Because I remember as a child just being very, very sick, just constantly throwing up bowels. My mom would let me just get into bed with her. I would just curl up and just wish I was dead. That's the type of pain. But to have that support, that positive, person in your life, or to have that support person to speak something positive in your life means the world.
You know, as I think about it, probably nobody outside of his mother has seen my husband Terry Wright suffer from what will ultimately be diagnosed as cystic fibrosis more than me. My husband and I actually celebrated 19 years of wedding bliss today. Can you believe it? However, when I met my husband more than 20 years ago, little did I know the life-changing journey ahead of us both. So let me explain. Although I connected to Terry right away, I could tell something was wrong. His face appeared sunken in, and he was constantly going to the restroom after he ate because he could not keep down his food. I couldn't quite put my finger on it, but I knew he wasn't well. Matter of fact, I knew something was terribly wrong. I even came to learn that he spent the majority of his tender years at Arkansas Children's Hospital without any type of diagnosis outside of them saying it must be viral. To make matters worse, he would make an average of 2 to 3, sometimes even 4 trips a week to the hospital because of uncontrollable vomiting and extreme excruciating stomach pain. One of his many diagnoses was chronic pancreatitis, followed by many surgeries, including even gallbladder removal, in an effort to treat this unknown condition. What was a moment that almost decades came full circle is when an Indian doctor told us Terry unfortunately had double pneumonia. That was really not a surprise. However, he didn't stop there. He also injected that if Terry were not African American, he would conclude that he had the classic signs of cystic fibrosis. We all appear to dismiss this revelation. Nonetheless, we continue our journey to find answers, because I knew if we did not get help soon, my beloved Terry was going to die. No sugarcoating here. After much research and desperation in 2001, Terry and I met with Dr. Clifton Parnell, who immediately told us that Terry had the worst pancreas he had ever seen in his 30-plus years of medical practice. All I can do is cry, because I saw the continual suffering, pain, and trauma on Terry's face and to his body. Subsequently, we decided to accept the risk, and Terry went under the knife for an 8-hour pancreaticojejunostomy to remove part of his pancreas and reroute his ducts. Following this major surgery and 1-month hospitalization, Terry's concerns migrated from his pancreas back to his lungs and the relentless flow of mucus in his sinus. Over the next 17 years, Terry would be hospitalized more times than I care to even count, with double pneumonia and extreme breathing issues. And to make matters worse, literally every medical specialist possible examined Terry and came to the same conclusion: double pneumonia, be it aspergillus, pneumococcal, mycoplasma, something even viral, to name a few, of an unknown origin. We even try to have children over the years with no success, not understanding at that time that infertility is a classic sign of cystic fibrosis as well. Following his hospitalization on multiple occasions in 2016 for double pneumonia, bronchitis, and sinusitis, we finally both had enough and made a desperate plea to infectious disease clinic at the University of Arkansas for Medical Sciences, also known as UAMS. You know, life has a way of coming full circle. The Indian ID physician that examined Terry at UAMS said the same words that haunted us roughly 17 years earlier: if you were not African American. But this time, he decided to at least rule out cystic fibrosis and sent Terry back to Arkansas Children's Hospital, the same hospital he spent most of his debilitating childhood, to take a sweat chloride test. And finally, after 54 or almost 55 years of suffering, Arkansas Children's Hospital, followed by subsequent testing at Johns Hopkins, confirmed Terry's shocking diagnosis of cystic fibrosis. As such, he is now under the care of UAMS Cystic Fibrosis Center and their multiple teams of specialists, and looks forward to celebrating his 58th birthday next year. However, my first question was obvious. Why in the world did it take literally 5.5 decades to diagnose what were the so very obvious classic signs of cystic fibrosis? Well, the reasons were both evident and heartbreaking, and to be honest, quite disturbing. He is African American, and unfortunately, assumptions due to his race and ethnicity were made, resulting in 55 years of an underlying unmet medical condition and diagnosis. And although it is devastating to think of all the years of suffering without an appropriate diagnosis, Terry has now made it his mission and passion through the founding of the National Organization of African Americans with Cystic Fibrosis, also known as NACFC or NACFC, to help raise cystic fibrosis awareness in the African American community, while serving as a beacon of hope to cystic fibrosis patients across multiple diverse demographics. NACFC and Terry's goals are to connect, help build diverse communities, and raise CF awareness in the African American community and beyond through its national platform, thus ensuring that all individuals, without exception, are appropriately diagnosed and treated for cystic fibrosis. This is our mission, this is our purpose, this is our duty, this is our responsibility. So please join us and let's make a change for the better in the diverse spectrum of cystic fibrosis for not only today, but for generations to come.
Want to briefly summarize my thoughts about hearing from a couple of different African American CF patients today. First is the idea of intersectionality. Here's the idea that our different social categorizations across race and other groups really create important systems that change the experience for individuals. So there's things that go along with having cystic fibrosis and things that go along with being African American, but being an African American CF patient is really a unique experience. Another thing that stood out to me was the strength and resilience from each person we heard from today. Even though there were lots of challenges, in some cases over years and years, both people were able to remain resilient and draw on their personal and collective strengths to overcome difficulties. And then finally, the importance of community. Both of our presenters we heard from today really emphasize the importance of community. And I like this quote that sort of summarizes why that matters. Community, meaning for me, nurturing human connection, is our survival. We humans wither outside of community. It isn't a luxury or a nice thing. Community is essential to our well-being. Inclusion in the social life of society is community's foundation. And a few take-home points from our presentations overall today, all 4 talks, for care team members. The first thing is to seek personal growth. It's important for us to take away from these presentations a drive to continue to develop and work on our biases and blind spots. There's no shame in that. Acknowledge cultural differences that do show up with patients. Don't be afraid to have tough conversations. Don't just focus on challenges when working with diverse patients. Also think about strengths that they may be able to draw on. Be aware of resources. Hopefully we've pointed out some today in our talks. Don't put that onus on the patient to be aware of resources. And then find ways for your team and even your institution to grow in terms of cultural competence. My final thoughts are, for a long time in CF, we haven't talked a lot about diversity. We were working on developing a medical therapies and a cure. We've made so many advancements. Now it's time for us to continue to grow a conversation about cultural competence. It's going to take a lot of time, work, and effort, but over the coming months and years, if we do this, we can provide excellent patient-centered care for all CF patients. I want to thank you all for listening and thank all of the presenters that took their time. And I hope you all will join us for our live Q&A. It'll feature the presenters as well as several of the people that you saw in videos today.